Hello, this is Cameron Sabat with Cutting to the Case, and I'm here with a classmate, Dua Mobin, and Dr. Lee Jones. And Lee Jones, MD, is a board-certified psychiatrist and nationally recognized leader in medical education, serving as Vice Dean for Education at Rush Medical Center, overseeing admissions, curriculum, and student affairs. He formerly served as Dean for Medical Education at Georgetown and is a professor of psychiatry. Dr. Jones has spent more than 25 years advancing student-centered medical education with a particular focus on equity, holistic admissions, learning environment, and physician well-being. Prior to Georgetown, he held senior leadership roles at major academic medical centers, including UCSF, UC Davis, the University of Arizona, and the University of Texas at San Antonio. Nationally, he served on the board of directors of the Association of American Medical Colleges, including terms as chair and chair-elect, and has led landmark initiatives nationally shaping medical student assessment and inclusion. Dr. Jones earned his undergraduate degree from Dartmouth College and his medical degree from Columbia, and is widely regarded as a compassionate and transformational leader in academic medicine. Thank you so much for joining us today.
It's such a pleasure to be here with both of you.
Yes.
Well, I'll jump right in with our first question for you. So, you have spent years pushing structural reform in medical education. What change do you believe mattered most in practice, not just on paper?
Well, that's a really wonderful and difficult question. I think that, and I was by no means the architect or the major person. It took a village to do this, is to really step back and look at who are the communities that we serve and who are the communities that we underserve, and really focusing on from the whole spectrum of clinical to service and including research, making sure that everyone is at the table in all of those arenas as we move things forward. One of my favorite things about Rush, one of the taglines you see around the hospital and the campus here is who gets to be healthy. And I think that's the focus. Ultimately, we go to medical school, we do residency to actually address healthcare and ultimately addressing health in people. And, the fact, and when I was at Georgetown, looking at the difference 8 miles made in your life expectancy of over a quarter of a century in the capital of the wealthiest country in the history of this planet. So I think that's the thing that I'm most proud of having been a small part of around education is bringing a diverse group of people, diversity of thought, diversity of background into medicine and enabling us to address those inequities as we move forward. We've got a long way to go, obviously, um, but it's part of the standard discussion now in a way that it wasn't years ago.
Yeah, I really appreciate that thoughtful response there. And kind of to follow up with that, what is a lot of reforms that you apply can stall at the implementation level? What distinguishes the institutions that translate reform rhetoric into durable change?
That is such a great question. Because what happens is when people that are really engaged are involved in those things and it goes nowhere, they get jaded and they don't want to be re-engaged in things moving forward. So it has the double whammy of that stalls, but also people that have been engaged can stall as well for future things. So I think what separates out um, organizations and institutions, as well as down to the department or clinical site, are a commitment, communication all along the way, making sure there's consensus and discussion, and really having a clear-cut map of where it is you're trying to go, being able to modify that and make it realistic, and also celebrating things as you move forward, just to maintain the momentum. And we all know these are really challenging times in the country and the world right now. And it would be easy to sort of bury your head in the sand or cover yourself with a blanket. Um, and it's really important to sort of move forward and celebrate and recognize that you are not where you want to be. It seems farther away, but you're taking steps to get there. So I think it's about clear communication, making sure that leadership understands that as a leader, I've had the last year to deal with this, but now I'm rolling it out to the people that are actually having to implement it and not expecting them to suddenly be where I am after a year, but really being able to bring them along either during the process or before we're asking them to implement things so that they understand. I think it's also really important as you're moving forward to sort of listen to what people have to say and Can we do this? If the answer is yes, great idea, we're going to do it. If the answer is yes, but later, great idea, we're going to implement it. If the answer is no, we're not going to do that. Here's the reason why. It's related to priorities because you want to keep people engaged and not feel like they're shut down. There also need to be the resources allocated, both the finances and the people energy and FTE to move forward there. And you have to have the right partners. I think they can keep you honest. I mean, one of the things that's wonderful, I love about medical education is you all, you keep us honest. You're paying a lot of money, a lot more money than I ever paid for medical school. And so it's important to go back to your constituents and say, are we achieving what we're doing and listening to what it is that their needs are? Did that answer your question, Cameron?
Yes, it did. I appreciate it.
All right, along a similar vein, our next question for you was what, in your opinion, is one widely accepted feature of US medical education that you think is misaligned with how physicians actually practice today?
Oh, wow, that's a great question. Um, I mean, things are advancing so quickly that it's very difficult. Quick story. When I was in medical school at Columbia in New York, we were in our abnormal biology course, pathology, pathophys, and we were in the oncology immunology section. And they canceled classes for 2 weeks, and they went away to a conference in Italy, and they came back and they said, throw away your syllabi. There's this stuff called NK cells and T cells and interleukins. And so we had to change our whole curriculum at that point. And when I started medical school, Hodgkin's lymphoma in kids was fatal. By the time I finished residency, it was treatable. So there's all these things that are moving forward. And when I think about um, things that haven't changed. The human body hasn't changed. Anatomy is still important. We have new techniques of ultrasound and MRI and those things, but there's a whole new set of things. Genetics has become much more important. The interaction between the peripheral immune system and the central nervous system. There's all these things that are difficult to move forward in medical education in a uh, timely manner because it takes so long to design things. So I think one of the challenges has been is how do we adjust our curricula to what's becoming important? We're all trying to address AI right now, right? That's the current one of how do we do this? I mean, it hallucinates sometime, and I know that's getting worked on. But there's so many ways that AI could enhance our ability to check things in a nanosecond that we were never able to check before. And so I think that the real challenge for us in medical education now is how do we just keep up? Which begs the question of can you really cover everything you need to know in 4 years? Medical school is still 4 years. Our answer to that, as an aside, or not so much an aside, is that we build lifelong learners. We build the scaffolding in medical school, and throughout the rest of your career, you have to take things off and hang new things on there. So I think that's really where medical education is challenged right now, is keeping up.
Yeah, and in addition to the curriculum in the medical education, you've also emphasized the learning environment just as much. What signals tell you that a medical school is getting that right?
You know, um, it's not that everyone's necessarily happy. It's not that everyone gets what they want, because where does that happen in life? It's that people feel like they are seen and heard and supported to go through what will be different challenges for each individual. If you come from a family that lost a family member to breast cancer, the oncology part is difficult. If you have someone that has a developmental delay, the neuro psych part is difficult. And I think being able to know that our students feel supported and connected, seen and heard in that, and that they're allowed to be human beings. I can tell you here at Rush, we had almost 15,000 applications this year for 144 spots. And the first thing is, can you do the rigors of the science and medicine that are required for medical school? But the next thing I like to say is, who would I want caring for someone I love? And being able to sort of connect those things and move things forward is really important um, to think about. And so I think knowing that people are in an environment where they feel challenged but not overwhelmed, because it is challenging to learn all this, but feel supported, challenged, and recognize they can do what we're asking them to do, and feel connected to what it is they're learning into the people around them. And they can see, looking at people around them, who they could be or where they could be or what they could be doing.
Our next question for you was, how do you believe medical education should respond to like the current generation of students who are becoming more skeptical of hierarchy, as well as, yeah, just more skeptical of traditional professional identity and questioning these, yeah, historic sort of like frameworks of like, yeah, hierarchy in medicine, basically.
No, and I think that's a question about medicine, but it's also a question about our culture in general, right? I mean, um, one of the things is if you talk, and this is before my time, or as I was coming up, one of the things that changed medicine a lot as far as responsibilities and ability to have a more well-rounded life is when more women started going into medicine. That changed things. And, there was resistance when you go back 50, 60 years, there weren't a lot of women in medicine. And now there's more women than men in medical school. And there was resistance to that, I'm assuming, because women have always been bright and wanted to do medicine. Um, and bringing women in, actually, while there was resistance, changed things for the better for all of us. So I think there are things within the generational differences, and there are clear-cut generational differences. I felt that moving forward, and I can see it in as we move forward now, where it needs to we need to step back and have a discussion about, is what the way we're doing it really the way it has to be done or should be done, and being willing to question that. But that has to be true on both sides. I've also had instances where students are like, why are we learning this, or this is wrong? It's like, okay, you have to wait for 3 more lectures. We'll get to why that was wrong. You're right. That study included only white men and didn't include women or other people, but we're going to get to that. Let me know if we don't get that. So it takes a conversation, I think, across the generations. And the other thing I would say is, it's while there are some broad generalizations about generations, there are people in every generation that fit with other generations. My husband and I have not had a landline for 30 years now. Most people in my generation thought we were nuts. How can you not have a landline? And so I think there are ways that people move forward at different rates, in understanding that. But are there things that we know from experience as educators in medicine? Yes. Are there things that students in a generation that are growing up in the time now know better than us? Yes. And being able to figure out how do we merge those two things in a way that's respectful in a conversation is really, really important.
Yeah. Oh, yeah. I really appreciate that. Yes. And, kind of to follow up on that idea of respect and just policy at an institutional level, if you could change a national policy or accreditation requirement tomorrow, what would most improve the student development and patient care?
So, the first thing that comes to mind, and there's several things. The first thing that came to mind, so I'm going to go with that because I'm a psychiatrist, and you go with what comes to your mind first, is the time-based element of medical education. Medical school is 4 years, residency is 3 years to 5 or 6 years, depending on the specialty. And that's assuming that we all learn at the same rate and master things at the same rate, as opposed to looking at competency-based things. The issue is that competency-based takes a lot more energy and time. It's much more complex. Um, but being able to recognize there are people that learn some things faster, people that learn some things and acquire those skills slower. And so what I would change, again, this would take a lot of energy and effort to competency based from just time based and passing certain exams, of being able to sort of look at, is this person where they need to be? Are they comfortable with this? Are they adequately challenged? Um, and there are some schools that are doing that. There are some schools that you can finish in your third year and start your residency in your fourth year if it's recognized that way. And many of us can extend to 5 years if we need to. But that's something I would change. There clearly needs to be a baseline. But what many people don't know is that states often have a minimum hours of requirement to get an MD in that state. And the reason I know that is when UC Davis went to a 3 year option for people, it was 3 years of medical school and directly into 3 years of internal medicine, they had to go to the state legislature to talk about changing the hours that were required, because clearly they were in medical school a whole year less. And that speaks to how sort of written in stone things are, when in reality, anything that's human is not written in stone that way.
Right. Next, I wanted to circle back to something you mentioned earlier. You mentioned the new hot topic within medical education, how to reform our curriculum going forward with the rise of AI. So I wanted to get your opinion as clinical environments integrate AI tools. What core human competencies must medical education protect at all costs?
Yeah, it's about the human interaction. Excuse me. AI really is a tool in our arsenal of things that we can do in the same way that keeping good documents, the electronic medical record, health record, can be both a blessing and a curse. AI can be that way. I remember a art installation in DC that I saw, and they asked 3 to 7 year olds to draw interactions with their pediatrician, and there was a certain percentage of them where the pediatrician had their back to the child typing on the computer. And that I'm not saying that's just pediatricians. All physicians in every specialty do that because we have these requirements. I think the risk for AI is that we lose the human contact that's so important. And that's the one thing that differentiates us from AI, being able to use it as a tool and recognize when it's not the tool that we necessarily want to use, but then taking what AI tells us and translating it into human interaction, so that there's a connection. Because when you look at it, all the data shows that, what increases compliance, what increases outcomes, what increases success, it's about the relationships and the communication that go there, in addition to the education, which AI can be helpful with. So I think we're going to have to attend to having this increase efficacy and efficiency, decrease amount of time that we as human beings need to spend doing that, and increase the amount of time that we actually spend with patients and explaining and connecting to them.
Yes, yes. And, about AI, where have you seen AI meaningfully improve medical training? And where has the hype outpaced the evidence?
So that's a great question. I'm going to take the second part first. So where is it outpaced, the hype? I think people don't recognize that sometimes things are just made up, and that, that old saying, garbage in, garbage out, is that you have to ask the right question. You have to have the appropriate learning in the learning model so that it actually can do things that make sense. So that's the other place that humans need to be involved. And if something looks odd, you need to check it out there. So where does it enhance medical education? It allows us to actually focusing on, so I'll go with radiology, chest x-rays. There are programs now in AI, from my understanding, that are incredibly efficient at finding chest x-ray radiologic abnormalities in a way that only very seasoned clinicians can do. Now, on the one hand, that could be very discouraging because I'm a medical student in intern in radiology or PGY2. How does that seriously, AI is going to do a better job than me? I think the answer there, though, I don't know why my lights are going off and on. I think yours just did too, Cameron. So anyway, thinking about how do we use that algorithm to actually ask AI, how do we educate people about what it is you're looking at? What are the details that you're looking at so we can use those as teachable moments with people? Think about how to move things forward with that. The other thing that comes to mind is I know there's several hospital healthcare systems that are running almost all of their EKGs through AI, that they automatically get read that way, and they are able to pick up on things that the routine machines and that routine don't pick up. And it's actually enabling us to learn about some early things that are connected with things that happen later that we didn't know about. So it's educating us, just contributing to the clinical information that we have, but it's also we can harness it to actually use to teach. Here's what AI is picking up on in those chest X-rays, and how do we, you know, teach people to look for those things? What are they, and how do you look for them? Did that make sense?
Yes, absolutely. Yes. I appreciate that.
Yeah, so along the same thought, I don't know if you've already been having these conversations at Rush or with like AAMC, but in your opinion, how should schools train students to use AI responsibly without outsourcing ethics or accountability?
Great question. So I think there's a couple of different extremes there, and I'll start with the two extremes. One is anyone that says we're just going to ignore AI. That's the wrong. It's here. We're already using it. My car uses it. It saved my butt several times by stopping before I even knew I needed to stop. And then the other extreme is AI is going to do everything. It's going to be the therapist. It's going to be the cardiologist. Those two extremes are just too wide there. Being able to think about where's the happy midline of that, where we move things forward and think about how do we incorporate this in a meaningful way that enables us to improve the care without impeding other parts of what we do. Did that answer your question? I feel like I didn't quite answer the question.
Yeah, no, that answers the question. I think I don't know if there were any specific strategies that you had in mind in terms of like how to use AI to help with like learning, like practice problems or like support like the pre-existing medical curricula as opposed to misusing it unethically.
Right, right. So I think the misuse, thank you, that's helped me reframe what I was thinking about. The misuse is trying to get it to do everything and to also misrepresent AI is your own work. Part of the issue with learning is that one of the ways we as a species learn is by failure and having to pick something up and look at it in many, many different ways. And so the mistake, I think, could be in the failure of AI is if you just look something up and don't try to understand it and don't have the ability, don't work with, and it takes a certain amount of struggle to actually I mean, there's things that all of us naturally can figure out pretty quickly, but often the more complex the issue, you have to struggle with it to understand what's the interplay, what are the intersections, what are how does that complexity fall out? And I think AI, we run the risk of if you can look up everything and take a picture of this and what is this? It's like that's great, but you need to be able to understand what it is you're talking about. I remember I failed the first two exams in medical school. They were biochem, and and I luckily got called in by the professor who said, "What's going on here?" And fast forward, I actually ultimately got an A minus because they graded for improvement, and when you're failing, there's a lot of room for improvement. But fast forward a couple of decades, well, less than a decade, I'm in residency in psychiatry. I left surgery at that point. And they put up a chemical signature of a new medication that's out. And then the person said, "What is that?" And I said, "Hell, that probably has amphetamine properties." First of all, everyone in the room was like, "Did Lee Jones say that? How did he know that?" But I was right. And it's like because I struggled, I actually remembered what amphetamines look like, as opposed to you use this dose and you do this, not understanding mechanism of action. So it's not, if AI, if we could do that, we wouldn't need doctors, right? We could just feed something in and AI would be take this medication at this dose. But there's nuances of things, both in treatment, but also in learning that we can't let AI replace.
And we've spoken a lot about the future here. I wanted to be respectful of your time, so this is the last question. Looking ahead 10 years, what would tell you that medical education successfully adapted to technological change rather than reacting to it?
That's a good question. I think where it is the technology, I mean, when you think back on some of the technology that has been successful, how has it been successful, and how do we know that? It gets integrated in such a way that we're not even aware that we're using it. Because it's so ubiquitous and part of what we do, but it also doesn't interfere with what we're doing. And so think about ultrasound. Ultrasound was once, the only OBs use that, and now it's point of contact in the emergency room. We use it all the time. We use it to find, so we don't have to stick people 30 times to find where the central line goes. And when you go back to, and there are schools now that you start using ultrasound in anatomy in your M1 year, and that tells me that it's successful. It's integrated. It's integrated from year one on up through multiple years of practice. It's used responsibly. We don't use it for things that's inappropriate. Everyone learns how to use it, and I think the technology, AI or whatever else is going to come, it'll be similar to that. 10 years from now, we will hopefully have figured out where the benefits are, where the boundaries are, where the dangers are, and it's part of our routine practice that allows us to be better at what we do. Ultrasound did not replace what doctors do. It just enabled us to do what we do better, with less pain and trauma to the patient, with more information. It's less invasive than an MRI, or it's certainly less invasive than exposure to radiation, kind of things. I think that's the model that would let me know that we have been successful. That I can go to an M1 student that's literally 6 weeks in as an M1 and say, tell me what you know about this technology, and they have an answer. And then I go to someone who's been practicing for 25 years, how are you using this technology? And they have an answer. And it goes across the entire spectrum. And then when I ask, how is this being misused? They can say, well, here's where it could be misused, but we're not doing that.
Yes, what a wonderful response. All the way from the beginning of their career, they are well aware of the technology and its perils and its promises, can integrate it adequately. I really appreciate you joining us today for this amazing episode of Cutting to the Case. And thank you, Dua, for being a wonderful leader in this interview. Yeah, and thank you both.
Thank you. It's been delightful. Great questions. I am so glad you guys are going to are my colleagues already and will be practicing colleagues with me. Apologies for the baton that we're passing on to you. I don't think I'm personally responsible for the craziness of the world, but we so need you, and I'm so excited, as are all my colleagues, that the fresh blood is coming in, and I feel really excited and relieved to be handing the baton to you.
And we miss you.
Ah,
We miss you.
I
Come
miss you
back
too.
someday. Visit
I've been
us.
keeping up with, I hear you have a new president. I just saw that. And
Hmm.
so I miss hearing about where you all are, and I'm sure everyone's moving toward graduation.
Yes.
So
Yeah. Very much appreciate it. This will be up by tonight.
great.
We'll
Thank
send
you.
it
Good
over.
luck with
Thank you so
everything you
much.
do.
Thank you so much, Dean Jones.
Yeah, yeah. See you soon.
Bye-bye.
Bye.